Good afternoon and welcome to today's presentation, Connecting the Dots, a case review discussion on how to optimize use and effectiveness of medical experts. The information presented by the expert is not to be used as legal advice and does not indicate a working relationship with the expert. All materials obtained from this presentation are merely for educational purposes and should not be used in a court of law since the expert's consent, i.e. a business relationship, where she or he is hired for your particular case. In today's webinar, Dr. Strayer will discuss qualities and what a good causation witness should do, how to optimize the effectiveness of such an expert, goals in retaining a causation witness, how a good expert should approach a case and advise attorneys, case studies, what kind of problems do you need to have solved, kinds of analysis can be applied to help establish the chain of events, how to optimize approach utilizing autopsies, their execution, strengths and limitations, immunochemistry, molecular analysis, and tumor doubling time. To give you a little background about our presenter, Dr. David Strayer is a professor of pathology, anatomy, and cell biology, as well as professor at the Sidney Kimmel Cancer Center at Thomas Jefferson University. He has served as an expert witness in over 100 cases filed in state and federal courts in Pennsylvania, New Jersey, Delaware, New York, Maryland, and Texas. Most of his work is on behalf of defendants, but has performed expert work for attorneys representing plaintiffs as well as those representing defendants. His expertise involves medical malpractice, industrial and other accidents, personal injury lawsuits. He strives to provide honest, objective assessment of cases, including hospital chart examination, pathologic evaluation of tissues, and laboratory studies, most questions regarding causation and progression of disease and injury, expert analysis of the behavior of many diseases process, including cancers, infectious diseases, inherited diseases, and many others. He has participated in and chaired over 20 professional grant review panels, including NIA, American Cancer Society, and others. Attendees who require passcode, the word for today is medical. During the Q&A session, we ask that you enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you're applying for CLE credit, you must log onto your computer as yourself and stay for the full 90 minutes. You're also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with a link to the archive recording of the webinar. The slides can be downloaded from the resource list at the widget at the bottom of your screen. Thank you all for attending today, and Dr. Strayer, the presentation is now turned over to you.
Good afternoon, at least on the East Coast. I'm going to talk about how to optimize your use of expert witnesses in medical-related cases in civil litigation, particularly causation witnesses. In this context, witness functions include the following that I will discuss. What makes a good expert witness, especially a causation witness? What are the professional and personal qualities that are helpful in this means? What do good causation witnesses do, and what should they do? Finally, how do you optimize the effectiveness of such an expert to make your case most effectively? So the value of a good causation witness especially is that he can help make a strong case, and he can help you to focus your energies and your acumen in such a way as to optimize your results. Strategizing is among the most important aspects of a good causation witness. He helps identify both the strengths and the weaknesses of the case as it exists and provides you with the input that you need in order to make your best courtroom strategy. In so doing, he can help you basically prevent you from being up a creek without a paddle. And a good witness can make an overextended case into a case that is both remunerative and effective from your perspective. So in the course of this discussion, I'll talk about how an expert witness as a causation witness particularly is effective and how they work. what they do best, and how they should function to help you most optimally. So the information that I'm about to present to you is derived from several sources, mostly experiential. It is a reflection of my experience as a pathologist, as a scientist, as a teacher in major medical colleges across the United States, and as a consultant to multiple government agencies, pharmaceutical companies, and of course, to law firms and other companies as an expert witness. This is my background that was touched on briefly. I have both MD and PhD degrees. My PhD degree is in immunology. I am trained in pathology from Washington University in St. Louis, and I've been on the faculty at 4 major medical centers in the United States. I have very extensive published expertise, as indicated here. I am the principal editor of one of the 2 textbooks of pathology that's used in medical schools in the English-speaking world. My experience as an expert witness is varied. Most of the time, I am a causation witness in medical malpractice cases, as indicated, most of the time for defendants, although I have represented or I have been retained by attorneys representing plaintiffs as well. I have also been standard of care witness. Obviously, there my expertise is as a pathologist who is opining as to the effectiveness and the accuracy and the adequacy of pathologic care rendered by pathologists. The majority of my time is spent in this context as a causation witness. I help connect the dots. I provide the stories. I tell the stories. I help lawyers to figure out exactly how events unfolded so as to focus their efforts optimally. I have written many case analyses. I've done many reports. I've been deposed many times, and I provided trial testimony in any number of different cases that are venued in the states that were indicated. Most, as I said, and was said before, reflect my work for defense lawyers. However, I talk to anybody who calls. So I will do this presentation mostly as a case-based study to illustrate the kinds of effective uses that you can use, to which you can put an expert witness in my situation. I will also focus on the qualities that I believe are most important for a good causation witness. So when you retain an expert, what do you want to do? From my perspective, an expert in my situation is most effectively used to help you understand what happened in a particular case, be it a medical malpractice situation or potential malpractice situation, be it an industrial or environmental exposure or accident, be it a traffic accident, be it work-related, any of those kinds of things. A good witness will also help you get an accurate assessment of the merits of the case. As you all know, some cases simply, however much one may want them to work effectively, don't. And it's best that everybody knows that at the beginning. Finally, I would like to try to help you identify the best way forward with your client's case so as to focus your strategy on the points that you find are going to be most effective with the advice of the expert. So these are the qualities of a good causation expert from my perspective. And they are all important. The final one is the most important. A good causation expert needs to be meticulous and thorough. He has to be able to go through the information available. In my case, that would be hospital records, it would be photographs, it would be pathology slides, it would be, excuse me, in the case of a workplace accident, it would be all the information about the workplace and its environmental protection, its OSHA-related protection, and so forth and so on. This is not a fast process. It's something that requires a great deal of attention to detail, and often, as usual, the key is in the details. A good causation witness also has to be able to connect the dots. His function, unlike a standard of care, for example, witness, is really to tell a story, to be able to draw it all together, to put the bow on the package, so to speak, to take the sequence of events in their detail and synthesize them into a story that makes sense. It is very important that a causation witness avoids jumping to conclusions. I've seen many, many cases where experts have taken what seems like a reasonable set of information and then gone off into left with it. Jumping to conclusions is harmful both to the attorney who is trying to present the case and to the client to whom the attorney represents. It's important that a good witness of this kind knows the breadth and the depth of the field. Specialized expertise is really important in some settings. However, a broad expertise and a broad appreciation for the way things happen and unfold, the kinds of situations in which various injuries, for example, will affect the body and how they evolve. It is very important that the expert sticks to the facts. I've seen many, many cases where experts meander off into speculation and from my point of view, fantasy. And from my perspective, you are on most solid ground and you can provide the best help to the attorney who has retained you if you stick to the facts. That way, anything that you conclude appears much more reasonable as a logical extension of the documentable facts rather than a flight of fantasy. Recognizing the limitations of the case is extremely important, as is recognizing one's own limitations. Everybody has their limitations, and everybody should recognize what they are. I learned very early in life, in my medical training, that the most important thing you can know is what you don't know. It's extremely important from the perspective of a causation witness to be able to say to the attorney who is retaining him or her that I can tell you this and this and this, but thus and such is beyond my expertise. And if you need information along those lines, you should find someone who is skilled in that area. A good causation witness avoids making assumptions. Assumptions are the genesis of many, many mistakes and many problems in trial in my experience. And in consequence, the best thing to do is to stick to the data. The most important characteristic of a good causation witness is the last one. As you will see in the cases that I'm about to present, honesty is not to be assumed. And it is probably the single most important and most effective characteristic of a good witness. And, excuse me, and is the single characteristic that helps the attorney who retains him the most. So, in this vein, then, a good causation witness will use the facts of the case to make a plausible sequence of events and a plausible story that is understandable. He or she has to be able to express himself or herself in plain language so that the story that he or she articulates is articulated in a way that people who are not expert in the area can understand. A good causation witness needs to be able to appreciate possible alternative explanations, especially in light of what experts on the opposing side of the argument have to say. Sometimes they're right, or they have a point. Usually there are many points that are made in the course of a courtroom discussion, and a good causation witness needs to be able to focus his attention on the ones that are most productive and to basically move away from those that are likely not to be productive in light of the expert testimony that the opposite side's witnesses are going to be presenting. In addition, in my experience, it's very helpful for expert witnesses to be able to suggest additional studies or alternative studies that may be useful in establishing the sequence of events. If the witness believes that more data are important to provide substantiation for contentions that are made, then he or she needs to be able to provide a mechanism for obtaining that information. So I'll move on to the first of these several cases. And all of these cases involve, from my perspective, illustrative areas in which witnesses, experts, have both succeeded and failed, depending on the situation, in advising the attorney to retain them. And I've chosen these cases, and the names and places, there are no names, but the places and everything else have been changed to protect the innocent and in some cases the not so innocent. So I've chosen these cases from my experience to illustrate the various qualities of causation witnesses that I've indicated I think are important. So the first case will illustrate the importance of meticulous and thorough examination of the case and the use of the facts of the case to tell a plausible story. I did, when I was in San Diego, have the pleasure of meeting a fellow who introduced himself to me as Guy Sell, and who drove a car with a license plate that said SCUSS, and it turned out, in fact, he was Dr. Seuss. So telling a story, which is what he was most skilled at, is one of the most fundamental aspects of being a good causation witness. And so I use this picture to illustrate that. Okay, in this case, a 48-year-old man complained of chest pain. He had a mild fever. His son simultaneously had a cold, an upper respiratory infection. Guy went to the emergency room. He had a chest x-ray. He had an electrocardiogram. Everything was normal. He was sent home with a diagnosis of chest wall pain. A couple of days later, he visited his primary care physician. At that time, he had a fever. He was vomiting. He had diarrhea. He was short of breath, and he was congested. His primary care physician diagnosed pharyngitis and sinusitis. At home, after he left the primary care physician a couple days later, he was vomiting and he had a fever. He was in bed, and suddenly one day he had trouble breathing, and his wife found him prostrate on the floor. CPR was unsuccessful. He died. An autopsy was performed. At that autopsy, a mediastinum is the middle of the chest between the rib cage anteriorly and the vertebrae in the back. And it includes the major organ in the mediastinum, which is the heart, as well as a lot of soft tissue. A mediastinal and paratracheal, meaning next to the trachea, abscess was found with mixed bacterial causation, lots of different kinds of bacteria. Aspirated material that had been vomited up, if you will, and then breathed down into the airways was found in his lung, and it blocked major airways. He was severely obese. He was also severely hypertensive and had extensive atherosclerosis. So a lawsuit was filed. The suit alleged that he died of sepsis that was caused by a mixed bacterial infection that resulted from an upper respiratory primary infection. The bacteria spread via the blood, that's sepsis, to diverse sites, and they caused metastatic mediastinal abscesses. Metastasis in this context simply means spread to a distant site. All of this, it was claimed, was missed by the primary care physician and the emergency department. The plaintiff's lawyers, as I will show you, were ill-advised by their witnesses. So the first thing to be done here is to analyze the information as thoroughly as possible. This requires careful examination of the autopsy material, especially the abscess, and integration of the clinical and the autopsy sequence of events into a coherent story that made sense. Here's that story. So the abscess contained, which is the soft tissues around his trachea, contained foreign material. That was a bone. And I've highlighted here several areas where you can see bony fragments, which are, I don't know if you can see my arrow, but they are circled here. In the lower frame, you notice that there's a lot of inflammation. The bone fragments were basically in the center of all this inflammatory activity. There aren't any bones in the mediastinum. There could only be bones in the mediastinal abscess if they got in from outside. Now, how could they have done that? Well, there's a very small number of ways in which mediastinal abscesses occur. They're listed here. 5 don't apply because of the clinical history. The 6th one, however, is much more likely, not because it happens more often than the others, but because all the others have been eliminated. Now, when I was a kid, I read the complete Sherlock Holmes, which was very disappointing to me because when it was done, there was no more, and I loved it. But one of Sherlock Holmes' mantras was that if you look at a situation and all the obvious causes are not possible because they are for one reason or another ruled out, then what seems extremely unlikely therefore becomes the most probable explanation. So it's worth noting that neither the pathologist who did the autopsy nor the plaintiff's pathologist found or noted these bone fragments. So there was no history consistent with any of the different kinds of situations that were present that are usually seen with mediastinal abscesses. The presence of foreign material, in this case bone fragments, and I can't tell on the basis of the morphology of the bone whether what the source of them was. It's just not the person's own bone. They could be fish bones, they could be chicken bones. The lawyer who retained me likes to call me the chicken bone doctor because of this, but they could have been anything, bones from any foreign source. How did they get there? How did they reach the middle of the mediastinum, outside of anything that has an opening to the outside? How did outside material get in? Well, there are only two ways. Either the bone fragments penetrated the esophagus because they were swallowed whole and made a perforation through the esophageal wall. That I consider to be the most likely. Or they were aspirated in the course of eating them and they penetrated the trachea. That's less likely, I think, because the trachea doesn't have the kind of contractile activity that the esophagus does. When I looked at the lung at autopsy, the conducting airways, shown here on the side, with the arrow indicating a bronchus, were blocked by the same material that was in the mediastinum. And you can see the arrows highlighting the bone fragments in the lung itself. So the aspirated material in his lungs was identical to the material in the abscess, including bone fragments. So the plaintiff had posited that the patient aspirated during resuscitative efforts. One can certainly aspirate gastric contents during intense CPR, but mediastinal contents, not gastric contents, were what this person had aspirated. Therefore, he had been vomiting. And the description of his death scene by his wife was totally consistent with his suddenly having aspirated well before any CPR was initiated. His lung airways were completely blocked as a result of this aspiration. Secondly, it's impossible to avoid the fact that the only way contents from the mediastinal abscess could have gotten into his airways was if there was a connection, either between that abscess and the trachea or between that abscess and the esophagus. So, a good causation expert in this context has to solve the puzzle. To put this case together, you have certain things you need to explain. He had swallowed or aspirated a bone. I posit a chicken bone, but it could have been anything else. A bit earlier, that painfully penetrated to either his esophagus or his trachea, probably the esophagus, causing him to go to the emergency room. This created the abscess because the foreign material in a place that's normally sterile generates inflammation, and it usually carries with it a great deal of bacteria from the mouth, from the from the original source of the bone itself. He aspirated that when he was retching, and probably that was what caused the clinical situation as it evolved. In that setting, the function of the causation witness was to produce a plausible story, and that's what happened. In this setting, the seemingly strong case that the plaintiff had, that he had an upper respiratory infection with mixed bacteria that disseminated via the bloodstream to cause this abscess, was much less plausible and made virtually no sense in the context of the foreign material that was present in the middle of his chest. The next case is a case involving illustrating the importance of avoiding assumptions and connecting the dots. So, as I said, a good causation witness knows how to connect the dots. He knows how to tell the story in such a way that it's plausible and is consistent with all facts. He also knows the field in both its scope and in depth. So a 64-year-old man who had no contributory cardiovascular history complained of sudden pain that radiated down both of his arms, and that's very important, and the backs of his shoulders. His immediate past history was that he had been at a carnival all of that day, and he was carrying his 5-year-old granddaughter on his head and on his shoulders. He went to the emergency room. Obviously, a man complaining of pain radiating down his arm is somebody who's going to be worked up for a possible heart attack or myocardial infarction. In the emergency room, he had serial electrocardiograms, and he had blood troponin values that were assayed over the course of several hours. Now, blood troponin is a constituent of cardiac muscle cells, of heart muscle cells, and when heart muscle cells die, which is what a heart attack is, it's released into the blood. The time frame between the death of the cardiac muscle cells and the time and the point at which troponin values start to increase is usually somewhere between 2 and 4 hours. He was in the emergency room for 7 hours, and his troponin levels remained normal. Cardiac catheterization was performed. It was also normal. His coronary arteries were not blocked. Unfortunately, he died suddenly 2 days later. No autopsy was done. Lawsuit alleged that the bilateral pain that was radiating down both of his arms was indicative of a myocardial infarction or a heart attack, and that was missed in the emergency room. They claimed that the negative electrocardiogram was because this was an atypical infarct. This happens every now and then. There's something called a non-ST elevation myocardial infarct, or an NSTEMI, which basically shows up without any dramatic changes in the electrocardiogram. However, the troponins in this case were normal. The normal troponins were ignored by the plaintiff and as they proceeded with the case. In point of fact, the repeated negative troponins for 7 hours make myocardial infarction extremely unlikely. Beyond that, clinically, the arm pain that goes along with myocardial infarction is virtually always on one side, almost never on both sides. In point of fact, the history of the case is that he is far more likely to have developed a nerve root compression as a result of his activities the day of the event, from carrying his granddaughter on his shoulder and on his head all day long. And that explains the bilateral radiating arm pain. The negative troponins, it does not explain his sudden death, but his sudden death may well have been, and probably was, unrelated to the specific incident that occurred. The way to have that, in point of fact, was to have done an autopsy, which was not performed. The third case I've chosen is not a medical case, so to speak. It is an automobile accident, and it emphasizes or illustrates the importance of knowing your material and of sticking to the facts of the case rather than going off into assumptions and speculation. When I was a child, there was a show on television called Dragnet, and the chief actor in the show, whose name was Jim Webb, played a man named Joe Friday, who was a sergeant in the Los Angeles Police Department, and his mantra was, "Just the facts, ma'am, just the facts." I use this case to emphasize the facts, and the fact that when you go beyond the facts or don't know your limitations in terms of interpreting them, that you get yourself and your the attorney who's hired you in trouble. So, this is a traffic accident. An elderly guy was crossing the street at a stop sign. He was in a crosswalk. A driver who had stopped at the stop sign was blinded by the sun as he was turning, and he didn't see the man. He moved into the crosswalk and hit him. The car continued on. The driver stopped when he felt that he had gone over a bump that he hadn't expected. The person he had hit was on his back in the crosswalk, unconscious, and just beside, right next to the right front wheel, the passenger front wheel. The person who was hit was bleeding from the back of his head. Multiple attempts at intubation by paramedics who were called immediately failed, and vigorous and prolonged CPR failed to resuscitate the person who was hit. Autopsy was performed by the medical examiner. It showed fractures of the right tibia, which is the shin bone, the right upper humerus, which is the upper arm, and several ribs bilaterally, as well as the sternum, the breastbone. There was a large depressed fracture in the posterior skull, which coincided with where his head hit the pavement. And there was an underlying hemorrhage in the subarachnoid area, which is basically just on top of the brain. There were friction abrasions, scrapes, on the right arm and the right leg, and there were contusions, bruises, of both lungs. The spleen was lacerated, as was the uvula, which is the little thing that sticks down from the roof of your mouth in the back. Neck and facial bones were intact, and that's important. There was blood in his airways and in his mouth. So a lawsuit was filed. The issue of responsibility was not contested. Clearly, it was not an issue as to whether this guy, the fellow who was driving the car, had in fact the responsibility for killing this person in the crosswalk. He was at fault. Question was, what was the mechanism of death and how did all of this eventuate? The plaintiff's forensics expert alleged that the driver heedlessly ran over the decedent's body. Basically, he said that the driver ran over the entire body, including the right arm and the right leg, the whole chest, the head. This was a 4,000-pound Ford Crown Victoria. So it's about approximately 1,500 pounds over each of the two front wheels. The purported going over the whole chest and the whole head was indicated to have caused the fractures of the bones involved, the posterior skull and the rib cage, as well as the humerus, as well as lacerating the uvula and lacerating the spleen. Furthermore, the plaintiff's expert, who was a forensic pathologist, said that the impact pushed the right side of the body under the car, so the car ran over the right upper quadrant of the abdomen, and that was why the spleen was lacerated. One of my favorite movies includes this quote from Magnum Force, from Clint Eastwood, and it illustrates one of the major problems with the plaintiff's case in this setting. You have to know your limitations. You have to know what the limits of your knowledge are and respect them. And if you don't have the specific information to do that to go beyond what you know, then you stick to what you know. Well, what happened here was that a good hand was overplayed. There was no possible path this car could have taken that would have directly caused all of the injuries that were observed in this situation. The pedestrian was lying on his back next to the passenger wheel. How the car could have gone over his entire body and have him wind up right next to the passenger wheel is not clear. The car could not possibly have run over his entire head and chest. The skull fracture could not have been caused by a car of that weight running over his head, as the fragile skull bones, both anterior skull, and which is to say the nasal bones, and the bones of the neck, which are very fragile, were all intact. The uvular tear was much more likely to have been a reflection of repeated failed attempts at intubating the man. The most likely, the locations of this person's fractures are indicated here. The most likely route of the car is indicated as well. He had abrasions on his right side, which is undoubtedly where the car drove. He had a fracture of his tibia and a fracture of his humerus, again reflecting the path of the car. There's a fracture in his posterior skull that is much less likely to have been due to the car running over the head and much more likely to have been due to the trauma of his head hitting the pavement. His spleen, as indicated here, is not on the right side of the body. It's on the left side of the abdomen. Anybody who takes first-year medical school anatomy knows that. And the plaintiff's forensics expert somehow did not. The fractured ribs were undoubtedly a result of vigorous CPR, which was administered for 20 minutes while they were trying to resuscitate him. Therefore, in this particular circumstance, what happened was the plaintiff's forensics expert overplayed his hand. If he had just stuck to the facts, and if he had recognized that he should check his facts before he made assertions, the case would have been about what the driver did and not about what was imputed to the path of the car. Time for questions.
Thanks, Dr. Strayer. If all the attendees can enter in the passcode for today, which is medical, and any questions that you have for Dr. Strayer. Our first question, what disadvantages does a plaintiff lawyer have in retaining an expert that does primarily defense work? Will your past opinions cause problems for plaintiffs?
No, I talk to whomever calls me. In honesty, I began doing this when I was contacted by a defense lawyer, and following that, the successful conclusion of that case, many of the people in her firm started retaining me, and that then snowballed. Other defense lawyers called me, and I continued to work with them. I've had any number of instances in which plaintiffs' lawyers have called me or have deposed me, and after the deposition said, well, I have another case, and would you be interested in taking a look at it? And I've worked with them. So I work with whomever calls me. I can't control the people who call, so those who call, and I'm happy to talk to them. I give everybody a dispassionate and, from my perspective, objective and honest assessment of the situation. I have no problem working for plaintiffs. I work for any number of them, and I don't think my approach is different.
Next question. How do you show an expert is dishonest?
Well, I'm going to show you a case in which the expert was, I believe, quite dishonest. There are a number of ways you can do that, and it's not an easy conclusion to draw. So I have had people call me, attorneys call me, saying, I need somebody who will write me an opinion that says X. When I hear that, I say, I'm not your man. I will look at the facts and give you an opinion that I believe represents the facts of the case. If you need somebody to give you a predetermined conclusion without having seen the data beforehand, then you need to find someone else. So the first way I think you can identify someone who is not completely honest is by looking at or listening to or paying attention to their responses to your questions. Secondly, if they look at a case and they say, well, I think we need to repeat studies, and I'll show you this in a second, studies that were done by the hospital because they can't possibly be right in order for you to make your case. That person is probably not going to be a particularly effective witness because what they are saying is that an accredited laboratory, for example, in this case, is not competent to do what is necessary in order for the attorney to make his case. The attorney needs to be able to make his case with good data generated by reliable sources, not by hokey data that's manufactured by someone who has a goal in mind. Beyond that, recommendations from other lawyers who've used this witness or not, people's experience with the witness. Has this witness been testified in cases that have been mostly settled in favor of the side for which that witness testified, or mostly in favor of the other side? What has been the course of those trials? Has this witness's testimony been effectively discredited by the testimony of the witnesses from the opposite side? The question you ask is a very good one. There is no easy way, but it's a matter of doing your due diligence in terms of choosing an expert. If it's a simple matter of finding someone who will tell you what you want to know, there are lots of people who will do that. That might not be very effective, and it certainly might not be very honest.
Next question. Is a good expert one who makes the best plausible explanation, or the one who makes the best plausible explanation in retaining party's favor? How can you tell which the expert did?
I'm sorry, I didn't understand the question. Could you please repeat it?
Sure. Is a good expert one who makes the best plausible explanation, or the one who makes the best plausible explanation in retaining parties' favor? How can you tell which the expert did?
That's an excellent question, and it's not an easy conclusion to come to. I would say that the way I would approach this is to say, basically, to the expert, would you give me the same answer if I were on the opposite side of this case with the same facts in hand? The expert is not an advocate. The expert is, if you will, a consultant, and his or her role is not to provide you with the opinion that you want. It is to provide you with the most plausible and most reasonable explanation for the course of events. That helps guide you in terms of, A, whether you're going to take the case or settle it or pursue it vigorously, or whether you're going to change your strategy in executing either the defense or the plaintiff's argument in the case. So if somebody can take, I've known cases in which, and this is a pathologist of whom I'm talking, received the same case from both the plaintiff and the defendant and gave diametrically opposite opinions to each. So the perspective here is, what would you tell me if I was on the opposite side of this? Now, I've had lawyers come up to me at deposition or after a case, after the defendant whose lawyer had retained me was excused from the case, either by a settlement or by excuse. And the opposing lawyer, so if I'm testifying for one of the defendants, the opposing lawyer, the plaintiff's lawyer, then approaches me and says, would you be willing to testify for me in this case? This has happened. And my response is very simple. The facts of the case are what they are, and my analysis of them is what it is. It doesn't change based on which side you're on. If what I said in my report is okay for you, considering that the defendant who was represented by the attorney who retained me is no longer in the case, then I'm happy to testify as to what I already reported. If you need me to say something different, then I can't do that.
And our last question for this section. I agree with your comment that experts should stick to facts and supportable conclusions. However, there are many experts who engage in a flight of fantasy. What is the best way for you as an expert to attack the opposing expert who does this?
Well, there are several ways. Perhaps the most effective way is for one of your experts to disabuse the court of the fantasy that the opposing expert is engaging in. Another possibility is to, when you are cross-examining or when you are preparing a cross-examination for this witness, to consult with your expert with regard to how best to approach attacking the veracity of the story that the opposing expert is telling. Those are the two ways I think are the most both expedient and the most likely to be effective.
Thanks, Dr. Shea. You can continue with the presentation.
Okay, thank you. Okay, so I got a question about the veracity of witnesses. This speaks to that point. And the issue I'm illustrating in this case is the integrity of the data on which the expert relies. So what you see here in this particular frame is a lung cancer on the left, which is highlighted by an arrow, and then a kidney cancer on the right, which is also highlighted by an arrow. The normal lung is surrounding the lung cancer, and the normal kidney is below the kidney cancer. And the point here is that a good expert should avoid assumptions and examine the data dispassionately And as I've tried to emphasize, be honest. So, in this case, a 58-year-old man developed a cough, and he had a slight shadow on his chest X-ray that was noted by the radiologist but was not pursued by his primary care physician. 2 years later, he had an enlarged node in the supraclavicular area, which means above the clavicle, on that same side. When that node was biopsied, it showed metastatic adenocarcinoma, which is a kind of cancer. And a chest X-ray at the time of that lymph node biopsy showed that there was a walnut-sized nodule in this fellow's lung. And you can see there it's highlighted. Now, analyzing this material, it makes sense that the tumor in the lymph node came from the lung. But making sense is not the same thing as it being the case, because the tumors don't read the books. They do what they want. And the tumor in the lung could have come there from somewhere else. So we have techniques, and I'll go through them in a bit more detail at the end of this discussion, that essentially help us try to determine where cells originated from. So tissues and cells produce antigens, which are cell surface or cytoplasmic structures, mostly proteins, but not always, that are characteristic of or specific for the particular tissue or cell type in question. So lungs produce antigens that are relatively specific for lungs, and colon produces antigens that are specific for colon, and so forth and so on. Tumors that arise in these organs or tissues often retain those antigens that reflect their tissue of origin. So we detect these antigens with antibodies. We use a technique called immunostaining or immunochemistry or immunohistochemistry. Antibodies are available that recognize those antigens and identify the cells that contain them and help you therefore determine from where those cells derived. And I've illustrated on the bottom of the slide on one side a schematic of a cell with antigens on the surface and an antibody that binds the antigens that is applied in a diagnostic laboratory in a hospital or a commercial lab. The antibody is linked to something called a chromophore, something that makes color, so that you can tell it on a slide. And I've indicated in the little immunohistochemistry inset at the corner of the slide what it looks like. In this particular case, you're looking at the brown pigment here, which tells you that the cells with the brown pigment are positive for whatever the antibody is supposed to be detecting, and the cells that do not have the brown pigment are negative for it. This, in fact, turns out to be a normal tissue. This is the pancreas, and you're looking at the islets of the pancreas, which are positive for insulin, which is what's being detected here, and the cells that make up what's called the exocrine pancreas, which produces digestive enzymes and things, which are negative for insulin. So this is an illustration of how this works. So the immunostain studies that were done on this man's lymph node suggested he had lung cancer. They were positive for lung antigens. They also did a molecular analysis that I won't talk about until the very end here. And with radiation and chemo and targeted chemotherapy that were guided by the molecular data that were available, the tumor regressed substantially. And what I've shown you on the bottom frames is control studies. That is to say, on the left side is the patient's a colon cancer, which was stained with the antibody that detects lung antigens, and you notice that it's negative. On the other side, you see the patient's cancer with the same antibody at the same concentration, and you see that it's positive, thereby telling you that this patient's tumor that was diagnosed in the lymph node most likely comes from the lung. Now, this man had regular scans, and a few years later, after he had begun treatment, and the treatment seemed to have been working effectively, a scan was positive in his kidney, indicating that there was something going on in his kidney that had not been there before. So they did an operation on his kidney, and they excised it. This particular tumor, which is shown here, invaded the renal vein, which is the vein that drains the kidney, and spread in contiguity, which is to say as one continuous mass up the renal vein into the vein that the renal vein drains into, which is called the inferior vena cava, and all the way into the right side of the heart. The hospital in which this operation was performed then analyzed the kidney tumor. And there are antibodies that will detect antigens for the lung and for the colon and for the skin. There are antibodies that will detect antigens for the kidney. And there are two aspects here that I want to emphasize. The histology of the kidney tumor and its behavior, which is to say invading veins the way this one did in contiguity as one continuous mass. This is very characteristic of kidney cancer. It is not characteristic of lung cancer. I can't tell you that it never happens with lung cancer, but it is far more characteristic of cancer of the kidney. Immunostaining analysis was done in the hospital, and the kidney tumor had kidney antigens, and it did not have lung antigens, as you see here. So the left frame shows the kidney antigens, kidney antigen analysis that was done in the hospital, and the right frame shows that the lung antigen analysis that was done on the same tumor in the hospital. The kidney antigens were expressed, the lung antigens were not expressed. Okay, the patient died shortly after that from metastatic disease. No autopsy was done. The plaintiff, and we'll talk about autopsies as a way of documenting your claim subsequently. The plaintiff claimed that the tumor in the lung had metastasized to the kidney and subsequently elsewhere, and that the delay in diagnosing the lung cancer had caused the patient's death. If the tumor in the kidney had come from the lung, then it ought to have expressed lung markers, lung antigens. It did not. It ought to have not expressed kidney antigens, which it did in the hospital lab. Hospital studies contradicted the plaintiff's lawyer's case and his expert's case. Therefore, a pathology quote-unquote expert in his own laboratory did another analysis with immunostains, the same analysis that had been done during the hospitalization by the hospital lab, and he claimed the opposite results. His new immunostains on the tumor in the kidney showed them to be positive for the same lung markers that the hospital stains were negative for, and showed them to be negative for the kidney markers that the hospital had found to be positive. Therefore, his own laboratory performed studies that contradicted the hospital's laboratory's results. This expert, contrary to the evidence, then concluded that the hospital must have done the stains wrong and had misinterpreted the tumor in the kidney. And he made this claim without presenting the obligatory control studies to show that, in fact, what he did to the kidney tumor, in fact, was negative for lung and vice versa. So without presenting those controls, those claims that the plaintiff's expert made could not hold water. Well, hospital labs have to be accredited, and they have to do immunostaining, like everything else they have to do, in accordance with particular protocols that are very rigidly defined by the manufacturer. And these labs are inspected on a regular basis by an accrediting agency. If they deviate from those procedural rules, then they lose their accreditation. The expert actually hurt the plaintiff's case. By giving the plaintiff's attorney what the plaintiff's attorney wanted, his data, which was very shaky and which was easy to point, and the lack of integrity of which was easy to point out, his data became the issue. And that distracted from the fact that there actually was a delay in diagnosing the lung cancer, and that delay, regardless of what did or didn't happen in the kidney, probably contributed substantially to the plaintiff's downhill course. So I use this final case as an illustration of the fact that the most important single characteristic of an expert is honesty. An expert, as I said, from my perspective, is not an advocate. An expert is a consultant, and his or her responsibility is to provide the attorney who retains him or her with a good a good interpretation of the data in hand. It is not to manufacture data that doesn't exist, which is what happened here. So, in this part of my discussion, I've tried to illustrate the importance of what I consider to be the most important characteristics of a good causation expert. Care and thoroughness, the ability to tell a story, the ability to connect all of the information that's available into a coherent whole that makes sense. Avoiding jumping to conclusions and avoiding approaching the data in question with some sort of mindset that dismisses data that doesn't work, that doesn't fit the preconceived mindset. The expert has to know his field. He or she needs to be expert in his field so that he or she does not make stupid statements like the spleen is in the right upper quadrant of the abdomen. The expert needs to understand what can be supported by the data and what cannot, and needs to be able to evaluate the data with an unbiased mindset. That's very important. But as I said, there is no substitute for honesty. So, in the next part of this discussion, I'll try to illustrate the kinds of ways that pathologists in particular can be useful to help make cases for attorneys in the context of medical legal proceedings. So, you want to know what actually happened. How did a situation reach the point that it reached? You want to know if it could have been prevented or treated. Had expeditious detection a chance of actually rectifying or reversing the course of this process? And who, if anybody, was responsible for the outcome of the situation? Now, many of these questions, not all of them, and not in every case, but many of them, in many cases, can be addressed by applying one or more of the following kinds of analyses. And these are the ones I'm going to talk about. Autopsies, immunochemistry, immunohistochemistry, immunostaining, it's all the same. Molecular analysis, and we'll talk about that. And finally, analysis of tumor doubling time. So what can autopsies do? Well, ideally, they will document the cause of death. They will tell you what disease processes are ongoing at the time the patient died, and probably provide you with a mechanism whereby you can track the course of evolution of this particular disease. Autopsies can also provide you with an indication as to the effectiveness or the ineffectiveness of therapeutic intervention, as well as potential harm that may have been done by therapeutic interventions. That would include medications. It is estimated that 250,000 people in this country die every year as a consequence of drugs that they take that have effects that are not intended by those who prescribe or administer the drugs. In addition, of course, in many autopsies, toxicologic analysis is very useful in terms of understanding the contribution of exogenous substances, not only medications, but also environmental exposures to the disease process in question. How reliable are autopsies? Here's the kicker. They're only reliable as the person who does them. Some people are very good and very thorough. Others are more superficial. And the question is, how thorough does the autopsy appear to have been to you? I can tell you that when I teach residents to do autopsies, we examine every organ for which we have permission. And we take, in a full autopsy, not including the brain, we take approximately 30 slides of all the different organs. The neuropathologist works for the brain and takes those slides separately. And there are probably another 15 or 20, depending on the case, that document disease or lack of it in the brain. So it's not only the pathology that an autopsy can document disease, it can also document the lack of disease. What can autopsies not do? In about 10% of cases, autopsies do not establish the cause of death. Why is that? It's because an autopsy can only identify disease processes that leave some sort of structural footprint. I'll give you an example of one that does. A heart attack. Somebody has a heart attack, heart muscle dies. Within a day or so of the heart attack, you can see clear anatomic structural changes in the heart muscle. It's very straightforward, and a good pathologist will have no difficulty identifying it. What can an autopsy not identify? An arrhythmia. If the heart is structurally normal and suffers an electrical insult, for whatever reason, there's an aberrant electrical charge that starts in the conduction portion of the heart, the nervous portion of the heart, and spreads abnormally through the heart that causes the patient to die suddenly. Happens all the time. These do not have structural footprints. They don't alter the structure of the heart muscle cells. They don't make them die directly. They happen too fast for structural changes to occur. So in those cases in which somebody dies of an apparent arrhythmia, it's not possible as a common rule to identify cardiac changes that are secondary to that occurred because of the arrhythmia, simply because arrhythmias don't leave those changes, don't leave those footprints. The other question that would be important for you to understand the answer to is how forensic autopsies may differ from medical autopsies. Well, it depends on the examiner. We have done very thorough autopsies my entire career, but I am not a forensic pathologist per se. I don't analyze whether the bullet came in at this direction or that direction, or whether the knife wound affected this organ or that organ. Many times forensic pathologists are the experts in these particular matters. Other times they tend, for if you will, traumatic or unnatural deaths, they may tend not to give as thorough an examination as a pathologist in a different setting. But everything in terms of the thoroughness and the effectiveness of an autopsy is going to depend on the person who's doing it. In many cases, a forensic autopsy and a medical autopsy will be the same. Other times, they'll be different. Forensic autopsies tend to involve a whole lot more analysis of toxicology than medical autopsies do. But either a forensic autopsy or a medical autopsy potentially can be extremely effective in documenting a cause of death and a course of illness. The next kind of study, which I've already touched on, is immunochemistry. Immunochemistry basically is a technique that uses antibodies to identify tissue constituents, mainly proteins, but not entirely proteins. And it's used in the following major applications. First, it allows you to tell if you have a disease that's going on, it allows you to tell what the tissue of origin of that disease process is. Most of the time here we're talking about tumors. It also allows you to identify foreign agents. So if you have a virus and if somebody has a viral infection and you're not quite sure which virus it is, you haven't cultured that virus during life. Sometimes viral cultures don't work very well, or they may take forever. Antibody detection of a virus and viral antigen is often very effective in identifying a microbial agent that's responsible for the patient's disease. And finally, they allow you to assess the extent to which a particular disease process expresses certain kinds of markers, tumor markers. And I use these here to illustrate, for breast cancer, to illustrate this particular point. Breast cancer, as you all probably know, is analyzed for certain substances that the tumor makes that may be treated or may be attacked therapeutically by different kinds of medications or agents. So estrogen receptor, which is shown on the left side here, is illustrated by the positive estrogen receptor breast cancer on the left and the negative estrogen receptor breast cancer on the right. Estrogen receptor provides a mechanism whereby medical oncologists can treat a patient with breast cancer using hormonal manipulation. Another kind of agent Now, I will say parenthetically that estrogen receptor is in the nucleus of the cell, and you can see that the positive, the little brown pigment things, are all kind of oval, which is the nucleus. HER2/neu, which is another kind of substance that is produced in some breast cancers and other cancers, is usually seen in an overlapping but generally different category or subset of breast cancers, and it is potentially addressable therapeutically using a series of antibodies against the HER2/neu, this particular antigen. And you can see here on the left, this is a cell membrane antigen, so it looks like kind of a lattice work or a mesh around the cell membrane of these positive cells. You can see on the left it's positive, and on the right it's negative for that particular antigen. So how does it help? Well, it can help you identify a foreign agent that caused a disease, be it a virus, be it kinds of chemicals, be it certain kinds of other infectious agents or parasites. It may easily be possible to use an antibody to identify what the particular foreign material is, whether it's infectious or parasitic or toxic. It can also, as I indicated in the case that I showed you, it can also help you figure out where a tumor arose if you have a metastasis. It can also help you figure out what kind of a process something is. If you're not entirely sure whether a process was traumatic in origin or infectious in origin or toxic in origin, there are times when immunochemistry can help with it. And sometimes it allows you to identify abnormalities that are not necessarily immediately obvious. So you can find, for example, if you have an index of suspicion based on the clinical data that the patient may have had a hepatitis virus infection, sometimes immunochemistry can identify that even if the direct histology doesn't. How reliable is it? In an unbiased hospital or clinical laboratory, which is accredited, it is extremely reliable. However, like all tests, it needs an unbiased interpreter. Molecular analysis is different. It does some of the same things that immunochemistry does, but does it differently. It looks at things in DNA and RNA. So it usually is used much less for the kinds of purposes that we were describing, and much more in a forward-thinking way of trying to identify mutations in DNA. So it can analyze only some DNA. It can analyze all DNA. It can analyze only active genes, which is to say most genes in everybody's body are quiescent in any given cell at any given time. So it can analyze only those that are active or activated. It can identify genetic abnormalities in terms of the numbers of chromosomes, and is extraordinarily reliable because it's almost entirely automated. So interpretation is really much less of an issue compared to immunostaining. How can it be used? It can either use fresh or fixed tissue, although these things, DNA, RNA, do degrade over time. It can establish paternity. It can establish ancestry. There are certain DNA and RNA characteristics that are characteristic of people of various geographic origins. It can help identify an individual. So if somebody basically has committed a crime and leaves saliva or semen or blood on the victim, then that can be used to identify the perpetrator. If you compare two or more samples from the same person, for example, tumors in one place or another, it can help you determine whether the tumor arose in one place and spread to other places, or whether you're looking at multiple different primary tumors, as we did with the kidney and the lung. It can also help you track how disease processes evolve by exactly the same mechanisms, looking for the same mutations. I'll show you how that works in a second. How does all of this work? Cancer is a clonal disease, by which I mean to say that virtually all cancers begin from a single cell, which starts out as a normal cell, and it acquires a mutation in its DNA by all sorts of different mechanisms. That alters the normal controls that the body exerts over those cells so that that cell is somehow unleashed and can proliferate regardless of the normal control mechanisms. And this is illustrated here. There's a normal cell on the bottom. it undergoes a mutation. And the mutation is shown here as a kind of purple tint in the cytoplasm of the cell. And that cell begins to proliferate. Its daughter cells acquire more and more mutations, and all of them retain the same mutation. So if the cells have they derive from that original cell. If they don't, they probably didn't. So the point here is that if you have a mutation that is present in a particular cancer, and its cells proliferate, because cancer cells do that. That's one of the reasons, one of the ways they kill people. There are going to be additional mutations that happen in subclones and sub-subclones and sub-sub-subclones of that initial tumor. Those additional mutations may make the tumor cells look a little bit different or behave a little bit differently. However, they will still generally retain the original mutation, which gives you a handle on what their origin was. However, if there is a second tumor that develops independently of the first, that will tend to have, usually, a much different first mutation. And its derivative cells will, and the second clone of a second malignancy is illustrated by a yellow tinge in the cytoplasm. In this particular case, the additional tumor cells will have additional mutations, but not that the first tumor does not have. But the first tumor will tend not to have the same mutations that the second tumor has. So analyzing molecular DNA characteristics, if you will, of these different tumor cells in different locations, you can get a handle on the question of whether a tumor that you find in one place is the same as or different from a tumor that preceded it in another place. Finally, tumor doubling time, which is an analysis that basically helps you track tumors over the course of their evolution. What is tumor doubling time analysis? There are two ways it works, fundamentally. Tumor doubling time approximates the amount of time that's necessary for a tumor to double in its size, to go from 1 cubic centimeter to 2 cubic centimeters, to go from the size of a golf ball to the size of a baseball. So we're talking about increasing in volume, not increasing in linear dimension. That's very important. There's a lot of literature that describes the normal range, normal quote unquote, of doubling times for particular kinds of tumors. So you know on the basis of a comparison with the literature that a colon cancer that metastasizes to the liver is likely to grow at a certain rate. This is very well documented. There is a range, however, and the literature range is not necessarily going to apply to every individual tumor. However, it provides a mechanism of analysis. How does this work? Tumor volume is usually assessed by radiographic means, like an X-ray or a CT scan or something of that nature. It is actually much more precisely documented by looking at serum markers, blood markers. So PSA for prostate cancer, CA19-9 for pancreatic cancer, and so forth and so on. These actually are a direct reflection of tumor mass. And if they are followed over time, then they can provide a reasonable index of how rapidly the tumor is growing. How accurate is it? Obviously, it's most accurate when you're looking at a person's individual tumor. It is less accurate or more, if you will, approximate if you are looking at the literature on the basis of a single snapshot of a tumor in size. What can it establish? The most important use of tumor doubling time in terms of legal activity, it can be used in terms of estimating therapeutic effect, it can be used in terms of understanding prognosis and the like, but in terms of legal activity, it can help establish how long a metastatic deposit has been in place at the time of its discovery. And therefore, the question becomes, whether that metastatic deposit was present at the time the patient visited Dr. X or Dr. Y. If so, did the doctor's manipulations change or not change what the course of the tumor was? Alternatively, it can be used to calculate back to a particular exposure. So suppose somebody was involved in an accident in a nuclear plant 5 years ago. Is that consistent with the fact that they somehow developed acute leukemia or a malignant liver tumor 5 years later? And the tumor doubling time allows you to approximate, to calculate back, to estimate back, is a better way of putting it, the possible relationship in time between an exposure and a possible consequence. So basically, I've illustrated it here, and I'll go through this quickly. Tumors start as a single cell, and it grows geometrically, 1 to 2 to 4 to 8 to 16, and so forth and so on. So it's important to understand that a tumor, which is 1 cubic centimeter in volume, which is probably, I mean, radiologists can detect a little bit smaller than that, but fundamentally it's about the smallest size as can be detectable by an X-ray. This tumor has between 100 million and 1 billion cells, and it has undergone, in order to get to 1 billion cells, at least 30 doublings, and that is assuming that all the cells survive. But in terms of total tumor size, it reflects about 30 doublings, and we'll talk about survival in a second. In point of fact, tumors don't follow a straight progression. What you see on the left side of this slide is the idealized schematic, but in point of fact, most tumor cells die, either because of insufficient nutrients, insufficient oxygen, or other kinds of local forces that limit their ability to grow. So when you look at how fast tumors in fact progress, they grow much more slowly, grossly, than you would think they do. The average doubling size of most solid tumors in adults is somewhere between 2 months and maybe 3 months, maybe 2.5 months. It's much slower than you would think. Hematologic malignancies, leukemias and lymphomas, and pediatric tumors tend to grow faster. They don't have the same kind of relationship to the supporting structure of the organ that solid tumors do. So, in this discussion, we've talked about the importance of various characteristics, both temperamental and professional, of causation experts. And I've gone through them in some detail. I won't reiterate them, but I think they're clear. We also talked about the uses to which the legal system can put certain kinds of pathology analyses in terms of understanding what happened to an individual person at a point in time, how things evolved, how things came to be the way they were at the time at which the patient comes to attention. And finally, a good causation expert can turn something that may be a tightrope walk into a slam dunk. He can help you make your case effectively and to target your courtroom strategy so as to allow you to have the most latitude and the most effective approach to trying to make your point.
Thank you, Dr. Strayer. As we are entering the Q&A, we ask that you enter the passcode into the Q&A widget, which is medical, and any questions that you have. Our first question, how or to what extent does an autopsy or lack thereof hurt or help a plaintiff's case?
Well, that depends on what the autopsy shows. My experience has been that, generally speaking, an autopsy almost always helps the plaintiff. And the reason is very simple. An autopsy generally will document the extent of disease and the nature of it, and helps the plaintiff establish the facts of the case at the time of death. Beyond lacking an autopsy, all of that type of information is speculative, and that makes it more susceptible to attack by defense attorneys and defense witnesses. The most documentation a plaintiff has in terms of establishing the course of events and their ultimate conclusion, the better the plaintiff's case is. Now, that doesn't mean that the plaintiff is going to necessarily be able to make the same case if they have an autopsy compared to when they don't have an autopsy. But if I were the plaintiff's lawyer, which of course I'm not, I would prefer to have the information and to be able to focus my approach to the case most effectively, because as I tried to make clear, I believe in having the facts, and the autopsy provides them to you. If the autopsy tells you that your original approach to, or the approach that you might have chosen originally in the absence of an autopsy is not going to be effective, then it allows you to focus your approach in a way that is more effective. And the lack of information always opens you to the counter argument to anything you say, anything, but almost everything, almost anything. It opens you to the counter argument that you basically don't have the facts to substantiate the speculation that in which you've engaged.
Next question. What is the significance of a family refusing to allow a medical examiner's request for a home investigation where the descendant dies at home?
In terms of the medical perspective, and I can't necessarily address the legal issues that are involved in answering your question. I mean, my gut would tell me that if a defendant's family, or excuse me, if a family refuses to allow a thorough investigation of somebody's death, that tells me that there's a reason why they don't want to do that and arouses my suspicions right away. That doesn't mean that my suspicions are necessarily justified, but it does mean that if I am in any way representative of the world at large, people who refuse to have something investigated, you think that there's something that's being hidden, which, as I say, may or may not be true. But in terms of medicine, you're always better off in trying to understand the course of events the more information you have. And so when you limit the amount of information that's available, and this is a general principle, obviously, but this is the way that comes to me to answer your question. If you limit the amount of information that's available, then you limit your ability to understand the course of events and how they transpired and how they evolved.
Next question. If driver ran over plaintiff, what difference does it make to know exact part of car that struck the exact part of body?
I'm sorry, could you repeat the beginning of that question, please?
If driver ran over plaintiff, what difference does it make to know exact part of car that struck exact part of body?
Well, if what you're trying to do, relative to, for example, the case that I illustrated with the car accident, it's a matter of confining yourself to the facts. So the relevance is that in a situation that's different from the one that was illustrated in this case, where obviously the person died because his head hit the ground following being struck by the car. So there was no question as to why he died. Okay, at least from my perspective in that case. But generally speaking, it's helpful to understand what the course of events was in terms of the specific part of whatever the the injurious agent was and how it impacted the body, because that basically tells you what the course of the person's death was, or the person's injury. In a case such as I described, the overreach, the fact that the plaintiff's pathologist overextended himself, basically detracted from the effectiveness of the case that ought to have been pretty much a slam dunk on the part of the plaintiff. And instead part of the case became about the overreach that they engaged in by trying to ascribe too much to the accident. The responsibility for the accident was clear. It wasn't even remotely in contention. So that should have made the case very straightforward. They complicated it by introducing extraneous speculation that simply couldn't hold water, and thereby subtracted from the effectiveness of their presentation.
Next question. What, in your experience, are the mistakes that attorneys make in cross-examining opposing experts?
What was the first phrase? I'm sorry, I didn't quite catch that.
Sure. What, in your experience, are the mistakes that attorneys make in cross-examining opposing experts?
Well, mostly what I can do is tell you the mistakes that opposing attorneys make in cross-examining me. Because I don't observe lots and lots of other witnesses. I do occasionally, but for the most of the time I'm only at a trial for a given period of time, and that's when I'm there, and whoever precedes me is maybe finishing up at the time I arrive. The most common mistakes, from my perspective, are those basically that are a result of inadequate preparation. So it's a consequence of trying to attack, for example, the opposing witness rather than what the witness is saying. It's a matter of not adequately consulting your own witnesses when the question is from what angle are you best equipped to discredit the explanation or the report that is proffered by the opposing witness. So my experience has been repeatedly that the mistakes that cross-examining attorneys make are generally those in which they are not adequately prepared. And I'll give you an example. There was one case in which I was testifying for a defendant. The plaintiff's lawyer, after my direct examination, got up and said, "How much did you charge for your services in this case?" And I gave them a number. And they said, "And how many pathology slides did you look at?" And they were like 4 slides or 5 slides. And they said, "So you charged that many thousands of dollars to look at those slides?" And I said, "I charged that many thousands of dollars and I looked at those slides." And the defendant's lawyer, who had retained me, then got up and redirect and said, "How many pages of the patient's chart did you go through?" And I estimated 2,500 pages. And in one question, the defendant's lawyer, who had retained me, made the plaintiff's lawyer focus on a per slide, if you will, charge of my part, look ridiculous. So it's a matter of having adequate groundwork and preparation. You need to be able to understand what the person is going to say, or is likely to have said, as indicated in the report, and then to be able to attack the specifics of the report rather than to try to dance around the periphery. I hope I've answered the question. Thanks.
Next question. Has the other side tried to discredit you by calling you a hired gun?
That's not one I've heard before.
Next question. When it comes to medical issues, is there a particular question or approach you recommend in verifying the expert is competent to comment on a theory aspect of the case?
That's an excellent question. Somebody's competence is not always readily accessible to easy analysis, shall we say. So one of the questions that I would ask is, what has this person done? What do they do in their career, and what have they done? Do they publish? Have they written articles about this? Have they made presentations to professional societies about related things? Is there a track record that you can follow in which they have a history of having had experience with this or that a particular kind of medical situation. What kind of doctor are they? If they are a pathologist, then they have no business talking about standard of care in any other specialty but pathology. However, if they are an obstetrician, gynecologist, do they limit themselves, for example, only to gynecology and not obstetrics? And therefore, they should not be considered necessarily to be expert in obstetrics unless they have a long and illustrious history in having practiced that. So you can look at the practice setting in which the doctor practices. You can look at the professional record of publications or presentations or attendance at meetings in which certain things are discussed. Those are, if you're looking at it from the outside, those are perhaps the most effective ways to approach the question of, is this guy expert enough?
Thanks, Dr. Strayer. That's all the questions we have time for today. We will send all unanswered questions directly over for them to be answered.
Thank you.
Please remember that if you're applying for CLE credit, you must have attended for the full 90 minutes of this presentation. You're also required to complete the survey at the end of the program. All certificates will be emailed in 24 to 48 hours. I want to take this opportunity to thank everyone for attending, and most especially Dr. Strayer for his time and effort in creating this presentation. If you would like to speak with Dr. Strayer, if you would like to speak with a TASA representative regarding an expert witness for a case that you are working on, please contact TASA at 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. Again, thank you all for attending. This concludes our program for today.
Rochelle, are you there? Hello? Hello?